Wilkinson. I'm a cardiologist and lipid specialist at UC San Diego Health, and it's a great pleasure for me to serve as the moderator for tonight's session. We have a great hour of CME. We're very fortunate to have Dr. James Trippi with us tonight, who will be giving us the following talk on lipoprotein A, a comprehensive understanding of its risk factors, burden, and treatment. This is such an important and timely topic. And again, it's a great pleasure to have Dr. Trippi here to walk us through lipoprotein A, to go through indications for lipoprotein apheresis. Really looking forward to this. Dr. Trippi is a cardiologist practicing in Indianapolis, Indiana. He's affiliated with multiple hospitals in the area, including Ascension St. Vincent Heart Center and Ascension St. Vincent Carmel. Dr. Trippi is an expert in clinical lipidology, cardiovascular disease, and cardiovascular disease prevention. He's really actively involved in the National Lipid Association, and we're grateful to all the contributions that he's made to the field and in support of the National Lipid Association, serving as president of the Midwest chapter of the NLA, serving on committees within the NLA. He is a stellar educator, a stellar clinician, and active in research as well, leading multi-center trials in the lipid space within Indiana, studying the effects of newer therapies to treat patients with familial hypercholesterolemia, other inherited forms of heart disease. And he is an expert in lipoprotein A and lipoprotein apheresis. He directs the Lipoprotein Apheresis Center at Ascension St. Vincent. So I'm really looking forward to tonight's talk. Again, thank you, Dr. Trippi, for being here. And this lecture was organized by Opus Medicus. This is a CME lecture, and Opus Medicus designates this course for a maximum of 1 AMA PRA Category 1 credit and an ABIM MOC point. Claim credit commensurate with the extent of your participation tonight, but Opus Medicus is accredited to provide these CME and MOC credits. So this is really a great opportunity. Again, really looking forward to this. I know I'm going to learn a lot. Everybody here is going to learn a lot tonight. Please put your questions in the Q&A, anything that you think of throughout the talk, and we will have a Q&A session at the end. So with that, thank you again, Dr. Trippi, and take it away.
Thanks, Michael, for the nice introduction, and good evening and welcome to everyone. Again, we'll be talking about Lp(a). I'll try to go over the basics of that and then talk about the only FDA-approved treatment for increased Lp(a), that is lipoprotein apheresis. Apheresis, again, being the cleansing of the plasma of atherogenic particles, especially Lp(a). I'd like to begin with some terminology. This can be somewhat confusing, so please indulge me, those of you who are very conversant in this, but to make sure everyone is on the same page. Lipoproteins are cholesterol and triglyceride carrying vehicles through the aqueous plasma, cholesterol triglycerides being lipophilic. You know this terminology. Every day you say LDL and HDL. Those are high-density lipoproteins, carrying vehicles for these lipophilic substances. Now, on the surface of lipoproteins are apolipoproteins. And why don't we just abbreviate them as APOs? And the proteins have been designated with names from the alphabet, A through E. And then there are subtypes of those proteins. And the interesting thing is there is a capital A, 1, and a little a. Here we see in the diagram a lipoprotein a. It's really just an LDL type particle. And on the surface, you can see the ribbon-like ApoB. And the ApoB here is attached by a disulfide bond to the apo little a. That apo little a is that colorful, crinkled up type structure on the outside of the particle. In fact, they're called Kringle units, each one of those. And they cause the LP little a, lipoprotein little a particle to have special characteristics. First, this little a protein, or apo little a, is homologous to plasminogen. So plasminogen, which breaks down clots, has competition from this apo little a, and therefore plasminogen is not able to break down clots as readily as if LP little a was not present. So there's more clotting intravascularly. This can cause all sorts of issues intraarterial, and clots on top of plaque is a dangerous situation. Furthermore, this apo little a that hangs off the side of the LDL-like particle interferes with removal of the particle by receptors. Ordinarily, LDL particles bind to LDL receptors, and the LDL receptor regulates the serum concentration of these particles. Well, with this apo little a hanging off the side, this LDL-like particle is not as readily bound to the LDL receptors, and as a result, these particles become stagnant in the circulation and become oxidized or stale because they are not readily removed. Literally, the surface, which is coated by phospholipids, become very oxidized, and then this particle becomes smaller and smaller, as you'd expect with an oxidized particle. Therefore, it's more readily absorbed into the vascular walls, and then because of all the oxidation, it attracts more defense cells because of this inflammation being present and oxidation being present. So therefore, we have increasing plaque formation as well as thrombus, a terrible combination. Finally, these particles are able to insinuate themselves into the vascular structure of the aortic valve, and over time cause the aortic valve to become stiff and lead to aortic stenosis. In fact, patients who have TAVR or transcutaneous aortic valve replacement, about 20% of them have that procedure performed because of high LP little a. So we have this triad of terrible complications. As a result, people talk about good cholesterol being HDL, bad cholesterol being LDL. I've heard LP little a being called the horrible cholesterol. And in fact, the cardiovascular outcomes are inversely proportional to the LP little a level. So the higher the LP little a level, the higher there are poor cardiovascular outcomes. And no matter how this particle is measured, higher levels lead to worse cardiovascular outcomes and MACE. The demographics are interesting. In the United States, about 20% of people have, and our citizens have high LP little a. Some patients have extremely high LP little a, about 1%, but 20% are well over the normal limits. And then there are founder populations. Certainly patients of Southeast Asian and African heritage will have higher LP little a levels, perhaps leading to the higher degree of cardiovascular disease in those populations. As a result then, LP little a is felt to be the largest unaddressed risk enhancer, and that's the terminology being used for LP little a risk enhancer of cardiovascular disease. If you look at any kind of diagram looking at the results of statin or PCSK9 therapy, you can see a dramatic improvement, but underneath the improvement, there is residual cardiovascular risk. In large part, this is secondary to lipoprotein(a) and probably to a lesser extent tobacco use. So here we have this Lp(a) particle that is so common in a population. First, there is some controversy in how it's measured. Lp(a) can be measured in nanomoles per liter or milligrams per deciliter. The two are not immediately convertible into each other, but the nanomoles per liter tends to be about 2.5 times the level of milligrams per deciliter, but that's approximate. In general, the terminology will probably gradually migrate so that all Lp(a) measurements are using the nanomoles per liter label. Unfortunately, in terms of treatment, we are lacking, and certainly it is known that statins and ezetimibe are ineffective in improving outcomes from high Lp(a). In fact, statins may increase Lp(a) by 10% or so. Ezetimibe has no particular benefit. Most recently, however, a very recent article in Journal of American College of Cardiology by Lacaze noted that the humble aspirin tablet may be helpful in some genetic subtypes of Lp(a). He noted that in patients who have a high genetic risk score, or kind of a combination of all the risks for atherosclerosis, versus those who have a particular genotype for high Lp(a), there was reduced MACE in those patients with the Lp(a) just taking aspirin, such that those taking the aspirin with the high Lp(a) had about 3.8 events per 1,000 person years, versus the high genetic risk score people on aspirin had 11.4 events per 1,000 person years. And this was all achieved without any increased bleeding in the when taking aspirin. So personally, I am not familiar with the research capability of determining the genotypes of Lp(a), and there are 2 or 3 or 4 that I'm aware of, but I think that's only a research tool. In general, the most common and the highest Lp(a) levels are found in these genotypes that respond to aspirin. So personally, in clinical practice, I use aspirin for all patients with extremely high Lp(a). Unfortunately, extended release niacin, although reducing Lp(a) levels by 15 to 20%, have never been shown to improve cardiovascular outcomes. Perhaps for any number of reasons, but using extended release niacin, some clinicians say at least it's something to do, and it may improve the Lp(a) minimally, but again, this is without any scientific evidence. Estrogen in the Women's Health Study years ago in patients with high Lp(a) was found when patients were supplemented for postmenopausal symptoms with estrogen and Lp(a), they had better cardiovascular outcomes. However, it's not recommended that patients be treated with estrogen for high Lp(a) in hopes of improving cardiovascular outcomes. Now, just in the last 2 years, PCSK9 inhibitors have been shown to improve outcomes somewhat. Schwartz and others had an elegant study in, again, the Journal of American College of Cardiology, and noted that even with low LDL cholesterols, treating patients with high Lp(a) using PCSK9 inhibitors improved outcomes compared to those who did not receive the PCSK9 inhibitor. So this is noted that the PCSK9 inhibitors may reduce Lp(a)s levels by 25 to 30%. However, at this point, that's the best kind of treatment we have. Perhaps PCSK9 and niacin, again, if feeling the frustration of not having a treatment and knowing the high risk of this particular presence of this incredibly atherogenic particle is a way to treat this. Unfortunately, PCSK9 therapy is not approvable for high Lp(a) and can only be approved when LDL cholesterol is over 70. So personally, in clinical practice, I will prescribe PCSK9s fairly liberally if an LDL is over 70 in those patients who have a very high Lp(a), hoping that there may be some clinical improvement. And then the coming attraction here is for the antisense oligonucleotide pelacarsen, which is in the Horizon trial, a phase 3 trial, and the small interfering RNA medication olpasiran in the Ocean trial are being studied for outcome trials and to see if they will improve outcomes in very high risk patients having high Lp(a). In these patients, we hope that we'll see an improvement in MACE or major adverse cardiovascular events. And if that's the case, they may be approved as soon as 2026 or 2027. So we have a few more years before these treatments are available. Pelacarsen has been reported to reduce Lp(a) levels by 80% in this antisense oligonucleotide mechanism. This is a mechanism where DNA, actually messenger RNA strands, are used to couple with the messenger RNA of the Lp(a) protein, and it shuts it off and reduces Lp(a) by 80%. The small interfering RNA of olpasiran, similar to the new anti-LDL medications of inclisiran, will be available probably 28 or 2029. So those are coming attractions, but at this time there is one FDA-approved treatment for high Lp(a), and now I'd like to concentrate on that being lipoprotein apheresis, or LA, as I'll use here. Again, lipoprotein apheresis has been used over the years for homozygous familial hypercholesterolemia after genetic confirmation of this serious disorder where atherosclerosis begins at a very early age. We recommend treatment begin at a very early age, and combining with other cholesterol-lowering agents such as statins, ezetimibe, bempedoic acid, PCSK9 inhibitors, lomidopide, and recently evinacumab, lipoprotein apheresis may be a valuable tool. We'll talk more about how this procedure is performed. Now, most recently, Lp(a), or lipoprotein (a), which causes very premature progressive atherosclerosis and angina pectoris, even with controlled LDL cholesterol, can be treated with lipoprotein apheresis. When doing so, and I'll show in a case history, it leads to a marked improvement of symptoms, functional ability, and a decreased atherosclerosis. A few words about lipoprotein apheresis now. It began when there was really hardly any way to treat extremely high cholesterol and its complications. It used fistulas, as in renal dialysis or peripheral venous access, but unfortunately, peripheral veins are difficult to use repeatedly. This procedure was only available in few centers, and again, our nearest center in Indianapolis is Nashville. So we have very limited availability. As a result, we try to offer this treatment to patients from a wide area and offer transportation for them for this procedure. Now, it's interesting. Lipoprotein apheresis is used differently in different countries. Some countries are incredibly liberal in using lipoprotein apheresis. Others never use lipoprotein apheresis. In the United States, we have somewhat limited use of lipoprotein apheresis. And certainly, we've been doing less lipoprotein apheresis since the advent of PCSK9 inhibitors, lamidopide, and recently evinacumab. However, there is two patients who that is fun with either of these. I'm wondering if we lost you here. I'm back. As a result, lipoprotein apheresis, along with evinacumab and lamidopide, are the only treatments in these folks who have very resistant LDL levels. Childhood apheresis is useful in homozygous familial hypercholesterolemia. As we said, lipoprotein apheresis. Renal diseases can be treated with lipoprotein apheresis, and there are access challenges with this procedure, and we'll talk more about that. Some patients receive this treatment as often as every week, others only once a month. There are different kinds of lipoprotein apheresis. The DALI, or direct absorption of lipoproteins, is done in some European and Far Eastern countries, but in the United States, dextran sulfate columns are almost used exclusively.
Dr. Trippi,
And there
I'm
are
sorry
other
to
forms.
interrupt you. Do you mind putting your slides back up?
I thought I have them up.
Sorry, we're
Are you not seeing
right
them?
now.
All right, let me try one thing here and see if I can share them again. Oh. I'm sorry for this.
Okay, we see them now,
Okay,
and they're full
sorry.
screen. Perfect, thank you.
All right, thank you for catching that. Again, the dextran sulfate columns for apheresis are almost exclusively used in the US. Here we see a little schematic of this. Cellulose beads have dextran sulfate attached to them. They have an incredibly negative charge, which attracts and binds the very positive charge of the ApoB that is found on atherogenic particles. So LDL has these ApoBs, as we saw, as so does an Lp(a), so does a VLDL, an intermediate density lipoprotein, but not an HDL particle. HDL particles do not have ApoBs, so they are not bound and are not removed from the circulation with this particular procedure. Also, inflammatory substances such as lysophosphatidylcholine and PLA2 and cytokines are removed from the circulation by dextran sulfate apheresis. Here we see a diagram, I hope you can see that, where blood is removed either from a peripheral site or, as we'll see, from a port. Heparin is administered, plasma is separated off, and plasma is pumped through one of these dextran sulfate absorbers. Once the absorber is completely coated and covered with lipoproteins, then we switch to a new column, and the old one is rinsed off in preparation to come back once the second one is coated. So they go back and forth between these two and then drain off the lipoproteins that are washed off of these columns. The plasma comes back and is returned with the blood to the patient. So there are significant advantages with lipoprotein apheresis: improves functional capacity, decreased angina pectoris, and many patients with Lp(a) will just have angina pectoris frequently with even what looks like fairly normal coronary arteries. Possibly decreasing angina pectoris is related to removing the acute phase reactants and the cytokines from the circulation. Furthermore, there are decreased vascular complications. So Lp(a) causes particularly bad peripheral artery disease, and you may be able to decrease the vascular complications of peripheral artery disease by removing the Lp(a). Lifespan is extended, at least according to the comparative trials, and it is a solution for the desperate few who have really no treatment available and have particularly aggressive and severe atherosclerosis. It's a difficult decision to undergo for a patient to come to the realization that every 2 weeks they'll spend 3 hours having a minimally painful procedure, but it's very annoying and it's a big step for patients. At this point, there's a lack of randomized clinical trials justifying the outcome, but there's strong anecdotal evidence. And I'll show you several trials at this point with the anecdotal evidence. Some people dismiss the anecdotal evidence and or the comparative trials by saying it's just a regression to the mean, and there's really no there's no proven improved outcome with apheresis. I disagree with that. So here are several trials now, many of which are done in children with homozygous familial hypercholesterolemia, looking at the results of Lp(a). So this is early data in 151 patients from the United Kingdom in 7 centers, where apheresis is done from age 1 to age 15. Therefore, we saw a decrease in LDL cholesterol of 43% on mean average and a mean reduction of Lp(a) by 38%. This led to a 62% reduction in major adverse cardiovascular events when comparing the 2 years before treatment to the 2 years following the introduction of lipoprotein apheresis. Here is the German experience. German medicine is very liberal in performing apheresis. They have 89 centers in Germany performing apheresis. And here is a study looking at the results from 2012 to 2020 in more than 2,000 patients receiving regular lipoprotein apheresis. During the first 2 years of treatment, there was a MACE reduction of 78% when observed and compared to the 2 years before treatment was initiated. So again, a somewhat anecdotal comparison. This is certainly not a randomized clinical trial, though. Here we see the Norway experience. In Norway and many Scandinavian countries, there is extremely high cholesterol levels in just 7 children and adults having homozygous familial hypercholesterolemia, which is about the usual average for a country of only 20 million. These are patients who are actually undergoing treatment. There are probably just as many who don't undergo treatment. But here we see the baseline total cholesterol on entry was 704 milligrams, and after apheresis drops to a mean of 162. They said the quality of life was similar in these patients having apheresis compared to the general population, which is pretty extraordinary in that these folks often have early death and multiple cardiovascular events, with the exception of 2 patients. And these persons had extensive cardiovascular disease upon entry. And so atherosclerosis did progress in these 2 despite lipoprotein apheresis. And they recommend that the later diagnosis of atherosclerosis led to less favorable treatment outcomes in these patients receiving lipoprotein apheresis. Here is a meta-analysis of 76 studies on 209 patients around the world in 45 centers, where there was mean LDL reduction of 63%. Of interest, xanthomata, the cholesterol deposits in the tendons, often seen in the tendons of the extensor tendons of the hand or the Achilles tendon, regressed or disappeared in 83% of patients. However, it's noted, and it should be considered that 123 patients, 24 of them experienced a cardiovascular event while on lipoprotein apheresis, about 10% or so. In this registry of patients recently, age 0 to 19, in more recent years, 50 children were treated at 15 centers, and there was a reduction in LDL cholesterol from 748 down to 179. However, 6 patients, that is 12% of those receiving lipoprotein apheresis, did develop cardiovascular disease. And again, the xanthomas completely resolved in 45% of these patients. Here we can see a diagram of how lipoprotein reductions of cholesterol work over time. The top line is homozygous familial hypercholesterolemia. The middle line are those patients with heterozygous familial hypercholesterolemia. Note that those with homozygous FH in 2 weeks, that is 14 days, have only a 17% reduction in their baseline LDL cholesterol. Now, if apheresis was done every week in those patients, they would only have a 35% reduction or return of increased LDL cholesterol. So it should be considered for homozygous patients to have lipoprotein apheresis on a weekly basis, and heterozygous familial hypercholesterolemia can go out to every 2 weeks. Let's be brutally honest about the disadvantages of lipoprotein apheresis. It's invasive. It's an invasive procedure, and there is some mild discomfort associated with this. There's inconvenience, as I mentioned earlier, and travel can be an issue. Very importantly, it often interferes with work, and maintaining employment can be very difficult. So trying to offer weekend sessions or evening sessions may obviate the need for patients to stop working, or we have some patients who continue to work and who have very understanding employers. It's an expensive procedure, and insurance coverage can be an obstacle. In general, we never initiate lipoprotein apheresis without assurance that it is covered by their insurance. Patient selection is important. In general, I try to make sure every alternative and every medication has been fully explored. After diet and maximally tolerated medicines have been used for 6 months and cholesterol remains high in patients with cardiovascular disease, then therapy can be initiated. Young patients should begin at a very early age if they have extremely high cholesterol. I have patients visit the lipoprotein apheresis facility, talk to patients while they're having the treatment, and educate them as to the procedures so they can have ownership and understand what they are about to undergo. And then again, we have to make sure that there's third-party approval. So for patients without cardiovascular disease, those who have homozygous FH and have an LDL greater than 500, even at a very young age, are recommended for treatment. Heterozygous FH, any LDL over 300 these patients are candidates. If there is cardiovascular disease and LDL persistently over 160 on full medical therapy, those folks are candidates. There is some talk about this dropping down to 100 milligrams per deciliter. Finally, Lp(a). And this is, we have been talking about this all along. Patients with an Lp(a) over 60 milligrams per deciliter with an LDL cholesterol greater than 100 milligrams per deciliter are good candidates for lipoprotein apheresis. Some considerations. In the past, fistulas were used. We really very much have tried to move beyond that because of all the complications. And you certainly are familiar with all the complications patients have with their fistulas during renal dialysis, requiring frequent declotting, surgeries, poor flows, and there is the possible complication of high output congestive heart failure. Port access takes care of all of this. It requires a surgical placement, but it's long lasting. Your arms are free during the treatment. There's minimal discomfort in placing the needles into the port, and they're specialized needles for access. And these ports are used only for lipoprotein apheresis and not for blood drawing or administration of medications. These ports have shown to be helpful and long-lasting with more than 1,000 punctures with the needles. So these port accesses are very helpful. After implantation by interventional radiology, it takes 4 weeks for the port to mature, as opposed to 8 to 10 weeks for a fistula. And here is the diagram using one of these ports that is placed in the subclavian area. You have to be careful. Nurses need to be practiced on how to access the ports and how to set up the machine, which is, I often look at it like it's a plumber's dream. There are cables and pumps and columns all over the place. Our nurses cross-train in renal dialysis. So if a patient is not present for the lipoprotein apheresis, they can be used in the dialysis area. We schedule times in the morning and the afternoon for lipoprotein apheresis. We'd like to be able to move to an evening time from time to time as well. We recommend patients have a topical anesthetic placed on the site about an hour before, and then we administer local anesthesia and Marcaine, long-acting local anesthetic for these folks. We recommend distractions during the treatment, headphones, TVs, videos, or a personal advocate being present. And for pediatric patients or very small patients, we recommend they have an albumin or saline priming infusion prior to lipoprotein apheresis and removing any blood to prevent hypotension from the extracted volume. There are some minimal complications with port access. There can be potential allergic reactions at the site to the heparin, to titanium structures, and the polyurethane. We've not seen this, but that's a possibility. Scars along the needle pathway to enter the port can make the needle access difficult. And we need very experienced interventional radiologists, and therefore the port cannot be placed too medial to the first rib where it may be pinched off from the catheter. At the end of a lipoprotein apheresis treatment, we infuse saline and heparin to keep fibrin and clots from forming in the catheter for the next 2 weeks. Pressure is applied to the site, and there is dressing applied to the site. Occasionally, if the patient is over anticoagulated, there may be some prolonged bleeding, and we've had that a few times. Hypotension and weakness and anxiety post lipoprotein apheresis occurs, especially in patients who are just beginning lipoprotein apheresis. The veterans just shake it off in general. I'd like to show a case history that really illustrates the use of lipoprotein apheresis for Lp(a). Please indulge me with this. This is a 41-year-old female. She's an aeronautical engineer, literally a rocket scientist. She had diabetes, hyperlipidemia. She was overweight, a non-smoker, normal blood pressure, but she started having angina pectoris at a very early age. And at that time, a cardiac catheterization was performed. She had a stent placed to her left anterior descending diagonal. 7 years later, she had 2 stents placed, one in her LAD and one in her left circumflex. About a year later, she had another stent placed in her mid left anterior descending artery, and 6 months later, a 6th stent was placed. A lipid consult was obtained. She was noted to have a very low apolipoprotein B, that is, the number of atherogenic particles was very low, and so that was a good sign. Her Lp(a) level, however, was very high, at 98, normal being 75 in the milligram per deciliter measurement. In the nanomoles per liter measurement, normal is less than 75. So again, Lp(a) milligrams per deciliter less than 30. I hope I said that properly. And then nanomoles per liter less than 75 is normal. Those patients who have milligrams per deciliter over 70 are at very high risk, or nanomoles per liter over 170 are at very high risk. She had a little bit of increased inflammation, HSCRP 1.2. She had early diabetes. We did some genetic risk tests. So she had a homozygous 9p21 genotype at that time, and she was heterozygous for an LPA intron 25 genotype, causing the Lp(a). Other genetic risk tests were unremarkable. She was treated with glycemic index diet and sitagliptin, metformin, canagliflozin, insulin, simvastatin, clopidogrel, aspirin, niacin, and ranolazine. Even with that, 5 months later, she had a repeat catheterization showing moderate 3-vessel coronary disease, and medical treatment was advised, but she continued to have angina pectoris. So about a year later, she had a 5-vessel bypass at age 52. In 2014, a month later, she was noted to have a very low cholesterol of a 111. LDL cholesterol was superb at 36. Glucose was a little bit high at 138, causing a somewhat high triglyceride as well. Just 2 months later, her left internal mammary artery occluded. A chronic total occlusion repair was attempted, but unfortunately was complicated by a femoral dissection and repair. She had unstable angina, was taking nitroglycerin at least every other day, had chest pain with any supraventricular tachycardia when she was lying flat or even with any exertion. She had increased medical therapy, all without any benefit. She had cardiac rehab a month later and had increased angina. It was worse if she had forgotten her isosorbide. She was working, but her exercise tolerance was decreasing. She was advised to consider a vegan diet, warfarin, or lipoprotein apheresis. And PCSK9 was applied for. This is in 2015. It was denied because her LDL cholesterol was less than 70. In 2015, she was recommended to have another CTO repair, but she was reluctant and declined. In 2016, again, 2 years after her bypass, repeat catheterization showed her LAD was occluded, and there were right to left collaterals, and her mammary artery bypass was occluded, her posterior descending artery was occluded, and her left anterior descending artery diagonal was occluded. Medical treatment was recommended, or chronic total occlusion therapy. She had increasing angina, decreasing functional capacity, went on a disability. She was very depressed, incredibly desperate, and totally emotional. Every office visit was in tears the whole time. At this time, a repeat lipid consult was obtained, and again, lipoprotein apheresis was recommended because of the Lp(a) at 143 nanomoles per liter. She, being a scientist, decided to get a second opinion and went to a very well-known apheresis center, and it was confirmed that she should consider apheresis. At this time, she also had carotid intermedial thickness testing, and she had bilateral carotid plaques. So right subclavian ports were placed, 2 of them, and before apheresis was begun, her Lp(a) was 196, and it was commenced every 2 weeks. Her post Lp(a) was 66 nanomoles per liter, and then 2 weeks later went back up to 176. Her hsCRP almost immediately dropped. And very early on, she had clinical improvement, increased confidence, and with just a few months, 2 or 3 months later, she had very infrequent angina, improved outcome, and she started planning a sabbatical at Oxford University. Unfortunately, as you can see with the date, that didn't work because of COVID. In March of 21, she had 2 months of recurrent angina, and this led to a CTO repair of the saphenous vein graft to the left anterior descending diagonal, but treatment of the LAD and native diagonal could not be opened. Cardiac rehab was commenced again. She was now able to exercise. She had paroxysmal atrial fibrillation and 1 27-beat non-sustained ventricular tachycardia post-exercise, but her ejection fraction was completely normal. Meds were then continued, including the addition of apixaban and sotalol. At this time, she had minimal angina. Then she had some increased shortness of breath, which was secondary to anemia, probably from all of these procedures, and apheresis. She received an iron infusion. In June of 21, her pre-apheresis LDL was 22. It dropped down to an LDL of 2 milligrams per deciliter. Her Lp(a) pre-apheresis was 177, dropping down to a level of 60. So for this patient, LDL cholesterol is controlled by statins, but progressive atherosclerosis secondary to Lp(a) continued. Her PCSK9 inhibition could not be approved because her LDL cholesterol remained less than 70. Her Lp(a) was effectively removed by lipoprotein apheresis and remains low, but returns to baseline in about 2 weeks. 6 years after beginning apheresis, now she has decreased angina, improved functional capacity following apheresis, and she has become our ambassador to new patients in the apheresis unit and talks to patients in her purely scientific way and tries to give them an unvarnished assessment of what going through lipoprotein apheresis is like. And in general, her clinical outcomes have markedly improved with lipoprotein apheresis. And yet one more case study. This is of a 36-year-old female with severe coronary artery disease, non-smoker, non-diabetic, had a 5-vessel bypass in 1999 at age 36. She had extremely high LDL cholesterol of 280 and an LDL of 210 on full dose atorvastatin and ezetimibe. Of interest, she had high bilirubin, which was felt to be Gilbert syndrome, and Gilbert syndrome is felt to be a negative cardiovascular risk factor. That is, it is said to decrease the risk of cardiovascular disease. Even so, this lady had a 5-vessel bypass at a very early age. She began lipoprotein apheresis after an AV fistula was placed in 2013. Her post-apheresis total cholesterol was 107 and her LDL dropped to 60. Again, the baseline was 210. We tried lamidopide. It was not well tolerated. She began on evolocumab, and you can notice her post-apheresis LDL was 56, just down from 60 with the addition of evolocumab. It didn't make much difference in this patient who had presumably null LDL receptors. Lipoprotein Apheresis was decreased to monthly, but the patient complained of being tired, achy, and run down and requested her treatments be increased to every 2 weeks. And we did so. She had no adverse symptoms, complications, or any cardiovascular disease from 1999 until 2020, when she had increasing dyspnea, was found to have severe aortic stenosis. Her last apheresis treatment was on October 20. At that time, a left heart catheterization, very importantly here, showed her non-dominant right coronary artery and her right coronary graft were occluded, but there was no new native vessel disease. This is now some 20 years later. A TAVR was considered, but she was not suitable because she had a small aortic root and close coronary takeoff. So a surgical bioprosthetic aortic valve was placed, and she had reimplantation of the left coronary ostium. She had immediate post-op course that was unremarkable and was going well, but then she had vasodilation post-aortic valve replacement, presumably from high output cardiac failure with the fistula, which led to acute kidney disease and shock liver with elevation of the liver function test. She had a prolonged hospital course. 2 months later, she was transferred to rehab. Unfortunately, evolocumab was not continued. She then had pneumonia in February of 21. She had a post-surgical visit. At that time, she felt to be weak, had weight loss, which she could stand, and had dependent edema. She was transferred home in March of 21, 5 months after having this surgery. She still said she was too weak to restart her apheresis, but had sudden death from myocardial infarction in April of 21. Statins, ancillary agents, PCSK9 inhibitors, and lipoprotein apheresis are often discontinued for various reasons. And they may be good or poor reasons, but numerous reports of major adverse cardiac events occur within months of discontinuing cholesterol-lowering therapy. Caution should be exercised in discontinuing apheresis or cholesterol-lowering agents for prolonged periods of time, even if there are other medical treatments going on. There are some renal diseases treated by lipoprotein apheresis. I'm going to just breeze through this. Focal segmental glomerulosclerosis responds nicely to lipoprotein apheresis, mainly because it removes some of these acute phase reactants, LPPLA2, oxidized LDL, the lysophosphatidyl-choline, fatty acids, and cytokines, which cause focal segmental glomerulosclerosis. Here's the protocol for that. There are special adaptations for small persons and pediatric patients. It's mostly used for renal disease in these folks, even more than the cholesterol. We strongly consider port access, or if it's just a short-term treatment, like with the focal segmental glomerulosclerosis, an internal jugular catheter can be used. Patients should have their parents accompany them. We consider local anesthetic at the site. The patient should be primed with fluid, and we use lower extraction rates. So that's where I will conclude my talk on Lp(a) and the treatment for Lp(a), the only treatment being FDA approved, that is lipoprotein apheresis. And here is how you can obtain your CME. And at this time, I guess we can have any questions that people may want to ask.
Thank you, Dr. Trippi. That was fantastic. Incredible overview: lipoprotein(a), familial hypercholesterolemia, current therapies, including lipoprotein apheresis. Thank you very much for that. We'll take any questions now. I don't see any currently posted in Q&A, but please get your questions in now. I'll keep an eye on the Q&A section. I wanted to ask you a little bit about lipoprotein(a) and your approach to screening patients. What's your current approach to identifying patients with high lipoprotein(a)? Who do you screen? How do you make that decision?
Well, the recommendations from persons who have increased experience with Lp(a) helps here. In general, lipoprotein(a) varies little throughout life. So it is recommended by many now that lipoprotein (a) be evaluated at least once in every patient in their lifetime. And this would be especially appropriate for those patients who are having early cardiovascular disease, have relatives who have had early cardiovascular disease, are those who have extensive cardiovascular disease and fairly normal LDL cholesterol or triglycerides. And then we'll see numerous persons who, most recently, this has been occurring, where some relative has a high Lp(a), or a parent of a child who's had some thrombosis and has only Lp(a) as the causative agent, will come and ask for their Lp(a) to be performed. In general, I try to have patients be evaluated with the Lp(a) measurement using nanomoles per liter, and I believe this will be the trend in the future. But once the Lp(a) is evaluated, and I do that in all referral patients to our lipid clinic, but not in all patients I see for general cardiology. Once it's identified and very elevated, then we can talk about prognosis, the possible ways to treat this. And again, unfortunately, statins, ezetimibe, and diet really have no impact on Lp(a), but they do certainly impact triglycerides and LDL cholesterol, which are certainly the source of atherosclerotic plaques. Many persons are coming to the opinion that LDL cholesterol leads to plaque formation, and Lp(a) leads to the inflammation of plaque and the susceptibility of plaques to be ruptured or eroded that lead to LDL cholesterol. So lowering LDL cholesterol is not to be minimized. That is very, very important for these patients with Lp(a). In fact, maybe even more important. Those patients who have familial hypercholesterolemia and Lp(a) elevation have much worse prognosis than just having familial hypercholesterolemia all by itself.
Absolutely. Thank you. I think that's a really important reminder that those are both measures that we should be considering for our patients, and that's part of a comprehensive risk assessment, not only the contribution of LDL and other ApoB containing lipoproteins to risk, but high Lp(a). We have a question. Yep. And we have only another minute here. So let's get to Kathleen Morris's question. In the setting of normal LDL, but mild to modestly elevated Lp(a), what is your threshold to treat with a PCSK9 inhibitor, including factors such as insurance coverage in both those with established ASCVD and in primary prevention, but with risk factors?
Well, certainly in those patients who have no significant atherosclerotic cardiovascular disease, it's all primary prevention. And in those patients, reducing LDL cholesterol is the first goal. And so if we can prevent atherosclerosis from occurring, then there's no factor, there's no issue with Lp(a) causing more inflammation of plaques, because there's no plaque there to begin with. So in those patients without established cardiovascular disease, I just go for the LDL cholesterol and try to get it as low as possible, much lower than I ordinarily might recommend for a patient in primary prevention. So trying to get the LDL cholesterol probably in these folks much lower than the usual threshold of 100 milligrams per deciliter, but probably going down to under 70 milligrams because of the presence of Lp(a). In those patients who have a normal LDL cholesterol but atherosclerosis, this is very difficult. Certainly aspirin therapy and perhaps other platelet inhibitors may be appropriate. And then, what to do about the addition of a PCSK9 inhibitor or one of these research trials. They are not eligible for a research trial with an LDL cholesterol of only 40. So it is a very, very difficult decision to try, again, just grasping for straws. Perhaps niacin may be appropriate. And again, reducing the cholesterol to remarkably low levels is appropriate.
And I think lipoprotein apheresis as well, like you described in your talk, is something to consider in that situation. I think that segues nicely into this question from Noelle Mann in the Q&A. She asks, I'm having trouble getting PCSK9 inhibitors approved in patients with extensive CAD, but with an LDL of 40. They also have a high Lp(a). So any suggestions there? I think you demonstrated very nicely in your first case that when you've done everything to lower LDL, Lp(a) is high, risk is high, that we have treatment options like lipoprotein apheresis. But in this case, would you currently try to get a PCSK9 inhibitor for a patient like this, even when LDL is low?
If there is, again, extensive progressive atherosclerosis, then yes, I will do what it takes to try to get lipoprotein A removed by lipoprotein apheresis, even with a low LDL cholesterol. It does take increased involvement on the part of prior authorizations and insurance coverage, but I think that's where you just have to use your clinical judgment and try to get apheresis approved if there is this progressive, terrible atherosclerosis that is just unremitting.
Absolutely. Well, we're past the hour. If there aren't any other questions, and I don't see any now in the Q&A, I just want to thank Dr. Trippi again for your time this evening. Great presentation, great overview for lipoprotein(a), FH, lipoprotein apheresis, some great cases to help us think about patients we might refer for evaluation by a lipid specialist to consider therapies like lipoprotein apheresis. I learned a lot, and thank you again for your time. Thanks everybody for attending, and remember to follow these instructions to claim CME and MOC credits. Thanks again.
Thank you.